Hello and good afternoon, everyone. My name is Sydney Bell, and I would like to welcome you to our webinar this afternoon. Today, our topic is FASD diagnosis, and we are going to have this presentation by Dr. Louise Scott. But before we get into that, just a few housekeeping things. I will be doing a land acknowledgement and going over a few of the housekeeping items for our time here on Zoom. So first of all, I would like to just point out that there is a menu near the bottom of your screen where you can mute and unmute yourself. I would ask all of our participants here to stay muted as we're recording this webinar to allow us to have a nice quiet recording. And I also hope everybody has seen the chat feature. So if you look at the menu that pops up along the bottom of your screen, a chat feature pops up along the side, and it's a great place to introduce yourself. I see that some folks have started to do that. Welcome, Sandy, from Red Lake, and I encourage everybody to post an introduction if you're so inclined. And it's a great place to also share any questions that you have. So please feel free to jot any notes or questions into the chat feature. So before I bring our guest speaker on, I would like to offer an acknowledgement to the land and to say that the Ontario Network of CAPC CPNP projects acknowledges and thanks the First Peoples of the territories where we work and serve and other Indigenous peoples for sharing this land in order for us to come together today. Well, so now I'm very excited to introduce to you our speaker today. Her name is Dr. Louise Scott, and I see she's come on camera here. Welcome, Louise. Dr. Scott's background is in neurosciences, and she continues to conduct research into children's recovery from acquired traumatic brain injury and sleep in FASD. As co-author, she has published articles in brain injury, pediatrics, and sleep medicine. Her interest in FASD began over 30 years ago, and she was part of the first 2 virtual Ontario FASD teams to be trained in Winnipeg. As a licensed pediatric neuropsychologist, she is on more than one FASD diagnostic team, as well as providing training and assessments within and outside of Ontario and internationally. Dr. Scott's private practice has continued to grow to the point where at least 70% of the assessments provided fall under FASD. There is a full neurodevelopmental diagnostic team within the practice, including neuropsychology, OT, SLP, clinical psychology, with a consultant pediatrician. Besides her commitment to the Peel, Brant, and London FASD diagnostic teams, Dr. Scott has established a very successful training service both nationally and internationally to other FASD emerging and operating teams, Child Protective Services, parent and community groups. So we are just really so excited to have you here, Dr. Scott, and just welcome you to provide us this exploration of the component parts of FASD diagnostic process for children and their families. So with that, I'm going to turn it over to you, Louise. And please feel free just to give me a shout if there's anything you need from me. But I'll be here monitoring the chat box and listening in. Okay?
Great. Thank you, Sydney.
Thank you.
So I'm glad that those of us who could join us today are here. This is something I spend most of my time doing. So I'm kind of always excited to share the diagnostic part of FASD. And I'm just having a little trouble getting my PowerPoint to actually change slides. Oh, there we are. Okay.
And Louise, for some reason, your camera off. Is that what you want it to be?
Yeah, I just found it easier.
Okay.
But I can put it back on if you want. But
up to you.
It's distracting for me.
Sure, no problem. I thought I accidentally turned you off. So.
No, it was me. Sorry.
Okay, wonderful. Please
So
continue.
I thought we'd start off with a little bit of, sorry, I also teach and at a university level, and I'm not really going to count this. There's no exam or anything at the end, but I have a little questionnaire I've used with physicians and teachers and lots of different groups about sort of the myths versus realities of diagnosis. And I thought we'd start with that. There could be a great prize at the end if I can find something, but it's just kind of to find out, because a lot of people think they understand a lot about the diagnostic part, but actually there's a lot of confusion out there. So this is really to help you understand where perhaps things have gotten confused along the way. And part of that is to review the new guidelines a little bit. They're not all that new now. They're almost 3 years old. And then look at the brain. There's two parts to every diagnosis under FASD. There's a medical assessment done by either a nurse practitioner, specially trained, or a pediatrician with special training. And then there's the other half of the diagnosis requires that there be shown to be the presence of a brain injury. And that's what my team does. And that's what I'm most interested in. And then there's some frequent hallmarks of FASD. I've been assessing kids with prenatal alcohol exposure for almost, I hate to say this, almost 40 years. And I've noticed some things that separate them out from the kids with traumatic or acquired brain injury and other kids with other forms of, say, neurodevelopmental disorders like autism. And I'm just going to review those a bit. So the first question is, only maternal consumption of alcohol is implicated in FASD. So you can just mark down if you want, whether that's true or false. You have a 50-50 chance of being right, so easy to guess. The second question is, the FASD diagnostic rate, or the prevalence, is related to social economic status. True or false? Third question, birth mothers of children with a diagnosis of FASD are alcoholic or have an alcohol abuse problem. True or false? Next question. FASD results in intellectual disability or lowered IQ? And then I've already kind of given you the answer to this one, so here's a freebie. Every diagnosis under FASD requires 2 separate and comprehensive assessment processes. And the bonus points are name each of the parts, which kind of also gives you the answer to the question. Next question. FASD is just the newest or trendy diagnosis. In FASD, confirmation of prenatal alcohol exposure means that the mother admits to having consumed alcohol during the pregnancy. True or false? So the first question is, only maternal consumption of alcohol is implicated in FASD. That's false. We now know that maternal alcohol use is just as important, plus we must ascertain other possible causes of pre- and postnatal brain injury, like poor nutrition, maternal physical health, domestic violence, use of street drugs, methadone. There's some very new information on methadone that says it may cross the placenta, unlike heroin, and actually do a bit more damage than heroin itself would do. Mom's stress level, transient lifestyle, opportunities for attachment, all those other things are just as important. And we know in FASD that the maternal alcohol isn't enough. Dad's alcohol use is important. And a family history of alcohol use is also important. And that comes from the work in the animal model in looking at epigenetics, and up to 2 generations of alcohol exposure can still result in some of the pups in the 3rd generation showing facial features, even if there's no alcohol that was presented during that pregnancy at all, which is a little scary. So we don't really know how to translate all of that into practice yet, but it is important to look at paternal alcohol use and maternal alcohol use prior to conception and afterwards. And certainly the family history of alcohol use is also very important. Whoops. There we go. The prevalence rate, is it related to socioeconomic status? No, it's false. This is a diagnosis associated with human beings across all society strata. Stats Canada reports at least 50% of pregnancies are unplanned, and binge drinking is increasing in younger, especially more educated women, which is, again, a very scary thought. But we know that no safe time, no safe amount, and no safe kind of alcohols is important. If a child, so we recommend, therefore, if you're a woman of childbearing age, avoiding all forms of alcohol if sexually active, and if breastfeeding, because that alcohol also crosses into the milk. So that can go on damaging the brain after birth. True or false? Birth mothers of children are alcoholic or have an alcohol abuse problem. Social drinkers are just as apt to produce a child with an FASD diagnosis because of that no safe time, no safe amount, no safe kind of alcohol. And in the almost 40 years I've been doing this, I met a lot of birth mothers. And I've met ones who, cut back to only 140 ounce a day, which is good. That's harm reduction. It's a good start. To those who really hardly ever drank, but there was a family wedding or frosh week's a big one, or something unusual going on where they just drank more than they normally would and they didn't know they were pregnant because it was too early in the pregnancy. So we know that brain injury, oh, I see the word nothing is so pale it's disappeared. Sorry, I changed the background. Anyways, there is, it has nothing, that's what the word that's missing. I guess that's why it completely got rid of it. I apologize for that. IQ has nothing to do with a brain injury. We know you can have a traumatic brain injury that can be to moderate to severe, the worst kind of traumatic brain injury, and it doesn't change your IQ. So IQ is not a measurement of anything to do with brain function. It's a measurement, it's associated with how you might do in school, but it doesn't actually change with a brain injury. So most of the kids I see do not meet criteria for an intellectual disability diagnosis, which would be a DSM-5 criteria. In fact, a lot of the kids I see, and the ones I worry about the most, are the ones who are cognitively intact and therefore have average to above average so-called IQ. Excuse me. But they have a lot of problems with executive function planning and socializing and other things, but their ability to do IQ tests is actually quite good. So, yes, it requires two separate, this is the one I said I gave you, I apologize, two separate and comprehensive assessment processes, and they are the medical consultation with a physician with specialized training, and then the second part is the determination of brain injury, and that's the multidisciplinary team. FASD is not the newest or trendy diagnosis. It's been around for over 400 years. People have known about it. And there are some religions actually where alcohol is banned for women, and especially women of childbearing years, because of that understanding that alcohol can damage. So we know that damage from prenatal alcohol exposure can begin at or prior to conception. So drinking just before conceiving is not a good idea. Or during conception is also not a good idea. And the animal model, as well as the epigenetics I mentioned, which is the several generations model, is very clear that alcohol goes on damaging long after the alcohol is no longer involved, because it can go on in other generations. FASD confirmation means the mother admits, no, that's not true. Mom does not have to admit. At this time, the three facial features is the same as confirmation of prenatal alcohol exposure. And sometimes people say 2.5 is pretty good. But really at this point, according to the Canadian guidelines, the new ones or the old ones, 3 facial features is the same as mom admitting. But it doesn't have to be mom admitting. It could be someone who was there, an aunt, a grandparent, a relative. As long as the people who are giving you this information are not in some way involved in a custody battle or something else, then it's fine to use that other information. Also looking for, was mom arrested for any reason, or in and out of rehab prior to conception? All those things are very, very important. Excuse me. So, hope you did well on the quiz. I'm sure you did, because you've already had a number of my colleagues from FASD1 presenting. So I'm sure that was quite simple for you. But I thought I'd just point out some of the realities, which is prevalence rates. We agree that we know that we don't really have a good handle on prevalence rates. But their ranges in the literature go from 2.9 to 28% of a population. That's pretty huge variation there. But the latest ones from Toronto, the study published most recently, said that it was averaging around 4 to 5%, give or take. So it's actually higher than the rates of autism, which people were complaining about were increasing dramatically, but not to the same extent as FASD is increasing. We need to understand the protective factors. We know there, and I've seen kids who were heavily exposed. I remember seeing a set of identical twins a long time ago, and that was the case where the mom cut back to only 140 ounce a day, every day, pretty much during the pregnancy. One of the twins, and as I said, they were identical twins, had the full facial features, but he really didn't have much in the way of brain injury. He was a little bit dysregulated around sensory, but it was really hard to find something. The other twin had no facial features, but he certainly had the brain injury. It was very easy to diagnose brain injury in him. So why is that twin-to-twin transfer that can happen during pregnancy where one twin takes more of the nourishment? We don't know. Taking more of the nourishment in this case may have meant more of the alcohol. We don't know. And we don't know why there's some ethnicities that seem to have some kind of protective effect either. And we're not even sure that that's true. It's just people believe that for a while. In France, for instance, they used to say they didn't have any FASD, but they have a state-supported system that really supports families. So when you come out of the hospital with a newborn, there's a nanny assigned to you from the government who spends a few weeks to a few months with you, making sure mom gets sleep, making sure mom knows how to breastfeed, take care of the baby, do all the things that we all love someone else to do when we come home with a newborn. And also they have state-supported daycare that starts early, and it's high quality daycare. And those kids, we don't seem to see the same prevalence rates. It seems to be lower. So maybe they're getting high structure and lots of support and using brain plasticity. Who knows? We don't know. I think we should, I know they're developing new biomarkers. There's some blood tests that are coming soon-ish. We'll probably hear more about in March at the international conference to identify babies at risk. And I think anybody who's at risk should be monitored by the local infant development program or similar service. And as problems arrive, they would be identified, followed more closely, and then when necessary, when the family is ready, referred to a FASD diagnostic team. And of course, prevention is really, really important. And that's why we need to know more about the prevalence rate, because then we can help prevent the next generation. And that's part of understanding how to integrate all this new information from epigenetics into our current diagnostic practices, because as I said, we don't really have a clue. Oops. So FASD is a neurodevelopmental disorder. That's how it's going to be classified in the new DSM-6 or whenever that finally shows up in that book with diagnostic criteria. It's a collaborative effort between the following professionals. I'll just briefly talk about what each one does. The physician's job is to make sure there's no other reason why the child might look like this or have these behaviors. Whereas and also to monitor behavior and medication, because prescribing for children with this kind of disorder is more of an art than a science. Social work does intake and follow-up. Social worker helps prepare the family. They're not necessarily in the cases with the teams I'm on where they actually look for the confirmation. That's actually done somewhere else. Excuse me, before the family actually would even get to the social worker, someone else has looked for confirmation that either there appears to be facial features or there's documentation that someone knows that there was alcohol being consumed during the pregnancy. And then it helps the family afterwards by trying to deal with this diagnosis. Because even if you go into a process knowing there's a diagnosis, actually hearing the words can be quite devastating, naturally. No one wants to know there's something wrong with their child. So we usually explain that a diagnosis, the only reason for giving a diagnosis is that it's a key that unlocks the door to get help that you couldn't access any other way. And as you know, there's not a lot of services out there to support kids with a diagnosis of FASD. So speech and language pathologist looks speech, language, and social language development in particular. That's very, very important in this group, that social language development is usually quite delayed, and their language is usually broken into, they understand far less language than they can use, which is the opposite pattern to normal child development, where we understand language people use around us, and then we start using that language. So this is complete opposite patterns. Well, the only condition I know where that opposite pattern appears. Occupational therapist is looking at all motor abilities, fine and gross motor. And one of the interesting things about these kids is that a little research project I was involved with the OT from the Peel Diagnostic team is that they tend to have better fluid balance. So when they're running, their balance is fine, but standing on one foot, they can't do. That's called static balance. And that's really difficult for them. But if they run like the wind and it looks beautifully organized, but it isn't when they have to stand still, cannot balance in. And of course, all the sensory dysregulation that occurs. I know in the new guidelines they've removed sensory, but I think there's a lot of literature out there to support it being in there. So most of the teams I'm on, we put it back in because it's something we find in about 100% of the kids. So obviously that needs to be in the guidelines. So we just added it ourselves. And then neuropsychologists, which is in order to find out if there is a brain injury, we have to do a direct assessment of cognition or thinking and problem solving, attention, memory, executive function, adaptive, and all the other areas that I'm going to talk about in a minute. So the new terminology in the guidelines is we had 3 diagnoses, including AR and D, which I never really liked because it blamed everything on alcohol instead of also saying poor nutrition, use, whatever else is going on. So now we have FASD with sentinel facial features and FASD without sentinel facial features. Those are the 2 main diagnoses. In order to get the first one with sentinel facial features, all 3 facial features must be present. And if you have 2 or 1 or none, then you get the other diagnosis without sentinel facial features. Although often people will note 2 out of 3, 1 out of 3, something like that. There's also an at-risk designation, which is not a diagnosis. So, and it's not one that we tend to use. The team in Peel that I'm on specializes and always has done diagnosing children 6 years of age and under. And so they used to give that diagnosis out, or that designation out at risk or defer, and they no longer do because of the way we've changed things around, the way we do the testing. We use brain injury protocols. So the other change is growth deficiency is no longer a diagnostic criterion. It certainly is in the States, but it isn't here. Changes in addition to the central nervous system criteria, they've added affect regulation, and existing domains reorganized and clarified. And then they've also got new guidelines for interpreting prenatal alcohol exposure levels. They're interesting, but they're recommendations, and it's important to remember that guidelines are guidelines. They're not diagnostic criteria, which they used to be, growth criteria. So when if you read the new guidelines, you'll see there's a lot of discussion about how much alcohol is the right amount. We don't have a clue in the literature how much is enough. There's a new study that came out last week that said that very, very little alcohol early in pregnancy did quite significant damage. So it depends on when that will be changing until we understand individual sensitivity reactions. So how an individual takes alcohol and processes it. So if you're like me and you're really sensitive to it, so you can drink a quarter of an inch in a small glass of wine and fall asleep, I don't need much alcohol. It actually affects me quite quickly, so I don't drink it. But someone else I know, a good friend of mine, can drink 3 bottles of beer and not blink an eye. She's fine. I would be completely comatose for months. So FASD with sentinel facial features, again, just to remind you of the 3 sentinel facial features, and I'll be discussing a little bit more about what each of these looks like. And we do recommend the use of the photographic analysis software. It costs about $60 US. It's quite reasonable to purchase. You don't need a special camera. It does a very good job of analyzing the pictures. And that's it's the website you get it from. So Susan Ousley worked very hard on that. It's probably going to be replaced soon, I would say within the next 5 years, with some kind of blood test of all infants at birth, hopefully, just like we do PKU and a few other things. So there must be evidence of impairment in 3 or more central nervous system domains that are listed. And it's interesting, even though the guidelines say that we don't use growth criteria anymore, it does say you should be confirmation PA in growth impairment and other things should be documented. So it's interesting, just in case they come back. It's partly a research project. FASD without sentinel facial features, you must again have the three areas of impairment, and confirmation of alcohol exposure is required. The first one, it isn't there, it just has to be noted because the three facial features give you confirmation. And again, they say growth impairment and other alcohol-related birth defects should be documented if present. And then here's the at-risk one. So we have to have confirmation that prenatal alcohol exposure was probable, highly probable. And maybe the child didn't meet the CNS criteria. Now, sometimes that's considered because they're too young. We don't find in PEEL that any child is really too young because the way we approach it. But if you don't have someone with experience in early neurodevelopmental diagnosis, it's hard to gather that evidence. But there must be some indication that there's some areas this child is having difficulty with, but maybe we just couldn't get it yet. They're too young. And that's, I think, usually what happens when people rely on questionnaires instead of direct assessment. And the teams that I'm on, we always directly assess every area. We don't just rely on questionnaires. But I know there are a lot of teams out there who don't have neuropsych and don't have people with specialization in brain injury, and especially early brain injury. So they rely on questionnaires, and then you don't get the information. And again, growth impairment must be documented. The problems with the at-risk designation, or the benefits, of both pros and cons to all of this, but the children when they're younger may not look that different than with developmentally, not talking about physically, but developmentally than other children. There's a huge developmental variability in a one-year-old when a one-year-old walks and starts developing language or using language. Huge developmental variability in those ranges of what's considered normal. By the time you're 5, those ranges have shrunk down so that there's very less variability as to when someone begins using, I was going to say fine pincer grasp, but hopefully that's long before they're age 5. But as children get older, they developmentally don't have as huge variation within their age group for a certain task or certain developmental task. And it says that, you may be able to use at-risk to access services and supports. And I find actually that diagnosis hasn't been very helpful when it has been used because no one knows what to do with it. FASD, they barely know what to do with quite often. So I don't think that actually is a helpful one. So here's from the team in PEEL, this is what we found, is that deferral or at risk may leave a child as not eligible for any services whatsoever, which is not helpful. You want to give them that deferring or the at-risk determination, I should say, instead of diagnosis. Sorry, it's my error at the top of that screen. But if it's not going to actually help them get what they need, then there's not any point doing it. Although sometimes giving any diagnosis is getting better than getting the wrong diagnosis. And I've certainly seen lots of children when they're older coming back who have a long list of diagnoses, none of which actually are correct. But and so sometimes it's better to use, there is one now in DSM-5 called unspecified neurodevelopmental disorder. And that's actually an accepted diagnosis under DSM-5. And I found that one, I can push a little bit more to get some help for children, just because it's in DSM-5, whereas FASD isn't yet. Although I know it's in the back of the book, but that's only for discussion purposes. And really any diagnosis for a child under the age of 6 relies very, very heavily on the clinical judgment experience of the OT and the speech and the neuropsych person on that team. And I think, as I said earlier, it should be followed by the local infant child development or similar service. And then as they get closer to diagnosis time, when parents and child are ready, then be referred off to a local team. If we had local teams everywhere, that would be great. The medical assessment, again, their job, the physician's job, is to identify any other possible causes for observed and reported behavior, and the facial features, if there are any, to look for them. The usual list of other diagnoses the child may have by the time they're referred to the FASD team is things like oppositional defiant disorder, attention deficit disorder, learning disabilities, and conduct disorder. And usually those are the ones we take away once we give the FASD diagnosis, because someone is given those diagnoses based on looking at the child's behavior through a very specific or selective lens, instead of looking a bit broader. And by definition, generally you can't have all these conditions if you have FASD diagnosis, because that diagnosis, FASD, is talking about a brain injury, which sort of therefore takes all this behavior into a new perspective. It's not intentional, whereas a lot of these are assuming the child is doing things intentionally. Or my difficulty with the learning disability label is that schools think if they put 2 or 3 things in place, boom, it's cured. And we know that brain injury doesn't work that way. Quite often you'll see older children with showing signs of depression and anxiety because the world is not making sense to them and they're frustrated. And of course, the number of children we've seen who have been bouncing around the system for a long time, and sometimes 4 or 5 placements in the first few months of life, we have to look at attachment disorder. And there's a lot of children we've seen adopted, especially adopted a bit older, say over age 2, 3, who certainly show very clear attachment disorder with the FASD, and that can go along with it. Now, attachment is considered to be another form of brain injury. So quite often the team will sit down and talk about, was there poor nutrition? Was there alcohol exposure? Was there any street drug exposure? Was there any problems with attachment? And we'll just start listing all the ways in which this poor little brain could have been damaged. And quite often we get up to 5 or 6 different ways, which is very sad. So just to remind you about what these beautiful children look like, the 3 things we look for in the physical exam are the philtrum, which is this little groove that you can't really see in this girl. Now she's kind of smiling, so it's flattened, but she's not really smiling, so it shouldn't be that flat. She has no philtrum. Her upper lip is quite thin. And there are differences within different ethnicities too. And then the rule of thumb is that this distance between the eyes is about the same as this distance, which is the opening of the eye right there. And that's what makes her faces look symmetrical. And in kids with prenatal alcohol exposure, this distance with the eye opening is smaller. So their eyes look wider set apart. Their eyes also can be wider set apart, but really it's the flattening here in the midface and this distance being smaller that makes their eyes look quite wide set apart. So they look beautiful in this young woman. And of course, growth is no longer a diagnostic criteria. So this is just one of the guides that are used to judge the lip, how thin the upper lip is. And this is obviously Caucasian. And of course, it changes over age. So the younger the child, the clearer it is, because kids tend to kind of, as you grow, your philtrum tends to flatten out a bit anyways. That's why it's probably best to do on the computer. And of course, in a slide just showing that when you smile, what happens to your upper lip and the philtrum, they kind of disappear. This is how the eye is measured if you do it by hand. When I first learned to do it back in 1970 something or other, I'm not going to say exactly what year it was, we actually did it with metal calipers. So you can imagine kids were not too happy about coming near their eyes with metal calipers, especially when they're pointy. So what you're trying to do is estimate this distance, which the computer does very, very easily because it's measuring pixels. So it's very, very clear. And sometimes it's like 2.5 centimeters and somebody will be 2.49 centimeters. And that's hard to decide when you're looking at a ruler. And this is what the computer program actually spits out, the page. So you know, it shows you the picture. This is a sample from their website. And it actually shows you the millimeter length, the true length, and how many pixels that is, and then the Z-score. So in this case, we have FAS features are absent in this child. He's an average child. NeuroDevelopmental Domains, this is when the rest of the team takes over. And these are the things that we look at in gory detail. So for instance, you'll see language and social communication. That's done by the speech and language pathologist. The occupational therapist looks at motor development and sensory. And the teams I'm on, we tend to put dysregulation in instead of just affect, which is one of the new areas. We actually say dysregulation occurs in many areas, sensory and affect in particular. And then the adaptive behavior. And the adaptive behavior is really how this child makes use of whatever they have up here on a day-to-day basis as independently as possible for their age to be safe and successful. And this is usually where kids do very, very poorly, is they can't use those abilities, even though we can measure them quite often. on testing that, their language isn't bad, but the social communication is a little low, but it's not too bad. But then you find that on adaptive behavior forms, this is one time we do use questionnaires, although we do it as an interview, that actually they can't make use of their social skills. So they either run away or they hit, and that's it when they get into a problem socially, instead of using words, appropriate words. So that's how we see the neurodevelopmental domains, but they all must be directly assessed. So it is possible to assess children under the age of 6. We've been doing that in Peel since 2006. We see behavior as a symptom of brain function. And we also importantly look at dysregulation in which setting. So just because there's a questionnaire that comes back that says, this child cannot regulate anything, and we look at the environment. If it's school, well, okay, we expect them to be able to use their executive abilities, or they may have more trouble using their executive abilities in school because of sensory dysregulation. But more importantly, the school is going to make, even a daycare center or nursery school is going to make a lot more demands on executive function than perhaps at home. So we expect there to be a difference between home and school. But that's why the direct observation is very important. And that clinical judgment and developmental knowledge is required. And I think infant and child development programs have that expertise that they're willing to share. In fact, they have a new booklet, the Peel team and a group from the surrounding areas have just published. It's available. If you're interested, contact me and I'll tell you how to get this book, how to identify and follow children who are potentially exposed to any substance, not just alcohol. And I mentioned this a bit earlier, the huge variability in population. Really, developmental variability is huge in younger ages, and it does narrow as kids get older. So what's the average age for walking? It's between 8 and 18 months. That's quite a wide span there, lots of variability. But when you get older, learning R's comes one of the last sounds, and that should be by a very specific age. So the variability for that is much lower. Questionnaires are not enough. Specific tests are based on brain injury protocols. We find that really, really helps identify these children much more effectively. And then one of the things, if you have a team somewhere near you or you can get to one, I suggest looking at Waterloo or Peel teams. They've both been running the longest consistently. If you want to shadow, I'm sure they'd be happy to have you. So some of the realities or hallmarks of fetal alcohol spectrum disorder that we've noticed over the years, once we've diagnosed them, and they become the things that we talk about when we're not so sure about a child's confirmation of alcohol use. Perhaps the physician saying, well, no one actually saw mom drink, but there was domestic violence. She was living a transient lifestyle. She had problems earlier in life with alcohol, with drugs and alcohol use, and was in and out of rehab. But really, does the child look like they have FASD? There's no facial features, but does the child's behavior look like that? So these are the things that we then turn to. And then it's still up to the physician to make the call as to whether the child meets criteria for a diagnosis, as long as we can prove there's a brain injury there too. So this is when the team works really well together. Sometimes we arm wrestle things out in gory detail, but usually we come to a fairly quick determination of whether or not the child meets criteria for one of those two diagnoses. So we noticed that the child understands far less language than they can use. A thin veneer of language competence is the way that the speech path in my office put it. And she's also on the Waterloo team, and I just love that phrase. And sometimes the child has such a thin veneer of language competence, it's pretty much completely transparent instead of just translucent. But they really struggle and they use language very, very appropriately in the right context, just as they know exactly what they're talking about, but actually they don't understand a lot of those words or the combination of those words. We all know that FASD, one of the hallmarks, is inability to perceive that consequences exist. And it's a hard one for people who are not familiar with this field to kind of wrap their head around. How can a child not perceive? If they did this wrong yesterday and they got into trouble, why would they not consider they'll get in trouble today? And I think from a neurosciences point of view, partly that's because their brains are not as good or fast at processing patterns. So they don't recognize the pattern. So if you sit down and talk to Johnny about next time Sally says something to you don't like, instead of striking, hitting her or slapping her, what are you going to do? Well, we're going to talk to her or walk away. And yep, that's right. But the next day, it isn't Sally that says something. It's Hilda. And when Hilda says something, of course, it's a whole new experience as far as the brain is concerned, doesn't recognize it. Even if it's the same comment or something similar I don't like, I'll hit Hilda. And the next day it's Sally again, but Sally's wearing a different colored shirt than she did the first time she said something I didn't like. So all those change the pattern. So that's why I think, I don't know, maybe I'll do research on this someday, why the kids have difficulty recognizing patterns. And we know they have trouble with habituation. That means you become accustomed to something. We know that the old studies that were done where you put a puff of air towards the baby's face and the baby would startle, full startle, and then very quickly you keep giving them a puff of air the same direction, hit their nose, whatever, and they'd stop startling and just kind of like, this is boring. And then you change the angle at which the puff of air hits their face, and they startle a little bit, not quite the same extent, and they even faster stop responding. That's what happens if there's no prenatal alcohol exposure. In children with prenatal alcohol exposure, for babies, you do that and they go on with startling. Brain doesn't seem to recognize that really, I've had this before, it wasn't threatening, I don't need to keep responding to it. But their brains do keep responding. Confabulation. Confabulation feels like lying when you're the parent or the teacher or the other side of it. So it's really because the memory doesn't work very effectively. They have trouble getting things out of their memory without external support, somebody on the outside. So the way I described it to parents is it's like there's a big, huge bank vault, big, thick door, closes, and it's locked. All the information's gone in there, but the child can't go get it. They need you to unlock the door for them. So when you do ask, well, what happened today or what happened in that situation, the child usually says, I don't know. Or you get some kind of interesting response, which may have nothing to do with what you've asked them to do. It may have a little bit to do with what you asked. So there might be some truth in it, but there's no guarantee there's any truth in it. So it's important to check out with somebody who doesn't confabulate, and more importantly, check out with somebody who isn't trying to set this child up to take the blame, because that happens far too often. And when a child's memory throws out information, which is what happens when you keep demanding some kind of response. So the memory kind of opens the door a little bit and throws out randomly some information. When that happens, it may be something from a TV show, it may be something from a movie, something that happened a year ago, whatever. In that moment, the child actually believes what they're saying because that's what their memory is telling them, so it must be true. So if you challenge that, you're calling them a liar. Nobody likes to be called a liar. You'll get behavior. Not good behavior, negative behavior usually. So it's really important to understand that when children give false information, or what appears to be false information, when you've asked them a question but they seem to believe it, they're not actually lying. When that happens in the presence of brain injury, we call that confabulation. And therefore we just use expressions like, thank you, I see, good to know, and then go check it out with someone else who, as I said, is not confabulating, and more importantly, is not setting the child up to take the blame. Dysregulation, another hallmark. In the areas of sleep, that's one of my research areas. There's lots and lots of ways in which their sleep is extremely dysregulated and easily treated. The younger they are, the better, with something called tryptophan, and that's the same thing that's in turkey. So if you eat turkey and you feel sleepy afterwards, that's because of tryptophan. So I joke with parents, you could feed a child 2 turkeys every night before bed, which might work if they're an adolescent male. But if not, then we can give them the tryptophan in a pill form or liquid form or cream form. But they also emotional control. They're pre-wired to be far more reactive because their cortisol levels are already higher than the base level of cortisol is higher than most people's. So it doesn't take much to get an overdrive. And they're totally relying on external environment to help them process information because the brain doesn't know with all this information coming in, it's the same. So my voice is as loud as the background furnace noise here is whatever, the car outside, all comes in the same. And they often do what's called misattribution. So standing in the playground, they hear someone cross the playground, your brain wouldn't pay attention to that voice at all, but this brain picks it up. And a child over there in the corner says, I hate him. I'm talking about something unrelated to the child in question. The child turns around and hits the kid next to them because they thought that person said it because that's where they thought it was coming from. It was as loud as, even though there's across the playground, to them it sounded just as loud. So that's why they react. No filters. And again, it's the sensory stimuli is arriving the same intensity. And they have trouble selectively attending to some stimuli and ignoring others. And that's why often you'll see kids need to think. In order to think, they need to move, and why they're so emotionally volatile, plus the fact that their cortisol level, which is a stress hormone, is already preset to a higher level. So I think of these poor little kids that's going around with all this sensory information coming in. They don't know what to do with it. It must be overwhelming. And I do think about that character from Charlie Brown of Pigpen. Not that they're going around in a cloud of dirt, but they're going around in a cloud of chaos. I think it must be very hard to know and to tie things to consequences if you can't understand where information is coming from. So emotional development, we know that they stop emotionally developing sometime before around the age of 6. So that the number of ways they can react to things is limited to that of like a 2, 3, or 4, or 5-year-old. And just like you do with a kid of that age, you have to go through that list of why are they acting this way? Like a 2-year-old, are they tired? Are they hungry? Are they frustrated? They can't find words, whatever. You kind of go through that list, and you continue to have that list. But it's kind of a full temper tantrum of a 3-year-old, but in a 14 or 16 or 18-year-old body. Again, developmental variability. One of the problems with these kids is they are developmentally all over the map. So you might be dealing with one ability 1 minute at 2-year level, next ability at 8-year level. And so you're constantly having to adjust your expectations as a parent or teacher. And I think that's why they're exhausting to parent or to teach. High reactivity, I already talked a bit, which is a high cortisol level coming from the HPA axis. So they can jump from 0 to 100 so quickly, because they're preset to be higher level of stress. And then the last one I've mentioned a couple times, integration of abilities and skills. Even when they have these strengths, they can't put them together. So if they need to do a task that requires working memory, processing speed, thinking, problem solving, something has to give. 1 or 2 of those things will give. So even though we can test in isolation the processing speed, when the child actually needs it, they can't access and use it, integrate it. And that's very different from kids with traumatic brain injury. So if you have any questions, I'm happy to answer them.
Hi, Louise. This is Sydney.
Yeah.
I guess I'd like to invite anybody who does have a question to either type it in the chat box, or if they want to unmute themselves and ask to go right ahead and do that. I guess, Louise, I myself was curious about, you made a comment about invitations for shadowing opportunities.
Yes.
Could you say a little bit more about that?
Sure. I know that on the Peel team and the Waterloo team, I was on the original Waterloo team. I haven't been on it now for a while, but we've had various people come and shadow the teams. They've actually come to a clinic and just looked at the process and listened to the discussion and the arm wrestling or whatever it is that's going on, and listen to how a team makes the diagnosis. Because I think that's the best way to understand what we go through. Sometimes it's, everyone says, yep, that's done. It's 2-minute discussion. Sometimes it's an hour discussion as we arm wrestle things out. But I think it's a wonderful way to understand as people, because we as a team present what we found, and we look for, oh, did you see this? Because if I see something motor, I may say to the OT, did you see any fine motor problems? Because I couldn't get this kid to hold a pencil. Oh, no, he had no trouble holding a pencil. Well, then we have to discuss why that is. And that helps all of us learn, but it's a great, just on the team, but it also helps anyone else who's there to understand all the factors that we are constantly trying to balance and discuss. The guidelines really don't give you that flavor.
Right. Well, thank you. That's fantastic. So I'm seeing a few questions come up. There's one from Sarah that says, asking about a copy of the presentation. Mm-hmm. And I'll just let everybody know that we've made a video recording of this webinar that'll be available on WebConnex, and also a PDF copy of Dr. Scott's slides. So those will be there. And Jackie, if you want to take your mute off, if you take your cursor and hover near the bottom of your screen, a menu will pop up, and you should see an icon that looks like a little microphone. And if you click on that, that should take your mute off. And while you're doing that, Louise, it looks like there's another question from Sarah. She's asking if you recommend a particular book to parents or teachers in English and in French.
A book of a specific topic? The one I hand out the most is Strategies Not Solutions from Alberta. It's still free. that's the general one I recommend. And then there's specific ones around, like the OT may have some on sensory processing, and the OT will write just a prescription or diet. It's called sensory diet to help this child's brain be able to cope a bit better. So we'll give it what it needs. So if it's deep pressure, how do you build deep pressure activities into the day? And she may have some handouts and books. Anything by Diane Melvin, I definitely recommend. And I mean, there's other one like Little Bear's Story. I can't remember that one. I think it's Sarah. Is it Sarah's Bear? No, that's the one for chemo. Sorry, there's one about a bear. And then the other book I really recommend is available from the Manitoba FASD website called But Michael Makes Me Laugh. It's written by a grandmother about kindergarten age, but I've used it with kids in grade 12 and actually at university. And it's a really nice book about sort of the worst possible day a child with FASD could have had at school and how another student turns that day around for that child. It's a lovely, lovely book.
Gotcha.
Whoops.
Okay, Jackie, I can unmute you myself, so I'm going to do that. And let's just see if that works. Jackie, are you there? I see that you actually typed in, I would like to have an opportunity to contact Dr. Scott. Are you able to provide your contact information? It looks like she's brought that up on her screen. So that should work. And folks are always welcome to also just feel free to send me an email, and I'll do my best to connect you with any of the presenters in our webinars as well. So are there any other questions for Dr. Scott? I would like to express my immense gratitude for you to come and speak with us today. I learned quite a bit, and really appreciate the breadth and depth of your knowledge of this subject and your willingness to come and share it with us. Very much appreciated.
Oh, my pleasure.
We'll definitely be letting all the members in our network who are unable to join us today how they can access this recording and learn from you.
Can I ask you a question of the people who were listening?
Sure.
Did anyone find anything surprising in the true and false part? Anything that were unexpected or something that shocked you or you thought you didn't know, or I don't know, I'm just curious because I like to update this questionnaire as frequently as I can.
Please feel free to unmute yourself or type it in the chat function if anybody.
Hi, this is Sarah.
Hi, Sarah.
Hi. So I wasn't, not in the true and false, but in the, I hadn't realized that the paternal consumption also mattered. I was unaware of that, so that shocked me.
Well, it's about time. The guys shared as one public health
Yes, I agree with that. It's about time the guys shared in the responsibility. Absolutely. Thank you for a wonderful presentation.
Oh, you're welcome. My pleasure.
Anybody else? Okay, well, we're ready to wrap up here, and before we say final farewell, I'd like to just remind everybody that our next network webinar is coming up on November 29th, and it's a continuation of this FASD series that we're hosting this fall. And the topic is FASD intervention and support. And that will be, our guest speaker will be Sherry Baum for that one. And all of the information to register is on WebConnects. And I'll keep sending out reminders with the registration links in our network newsletters. And with that, I think we are finished for the day. So thanks to everybody for coming and joining us this afternoon. And again, a very special thank you to Dr. Louise Scott for coming and sharing her knowledge with us.
You're welcome.
I hope you all have a wonderful rest of the day and take care.